Good evening all. Good evening, sir. Sir, shall I start?
Yes, please, ma'am.
A 64-year-old gentleman, Mr. N, who is a farmer by profession, hailing from Coimbatore, presented with complaints of yellowish discoloration of eyes and passing of deep yellow urine for the past 5 months, loss of appetite and weight for the same duration, passage of white-colored stools for past 5 months, itching all over the body for past 4 months, and mass in the right upper half of the abdomen for past 4 months.
Okay, I'll proceed.
History of presenting illness. The yellowish discoloration of eyes was first noted 5 months back, gradually deepening over the first 3 months, following which there was a diminution of yellowish discoloration in the next month. But for the last 1 month, the yellowish discoloration is increasing in intensity. There was no associated fever, arthralgia, malaise, skin rashes before the onset of discoloration. He also complains of progressive itching all over the body, especially over the abdomen, chest and lower limbs, which increases during evening and nights, disturbing his sleep, relieved by scratching over a period of last 4 months. Patient is passing. Sir?
Complete your history fully.
Yes, sir. Patient is passing white-colored stools for the past 5 months since the onset of yellowish discoloration. History of passage of black, tarry stool 2 months back, which lasted for about 7 days. Passing stool twice a day with no history of alteration of bowel habits. The patient also complained of loss of appetite and loss of weight for the past 5 months. No history of vomiting or hematemesis. The weight loss was noted when she found her clothes to be loose-fitting, and the exact weight cannot be ascertained. No urinary complaints except for passing of deep yellow urine for the past 5 months. Lump in the upper right abdomen, first noted 4 months back, which was insidious in onset and slow in progression, not associated with pain. No history of headache, seizure, dizziness. No history of cough, chest pain, hemoptysis or bone pain.
Okay.
Yes, sir.
No, proceed.
Okay. Past history. The patient is a farmer belonging to low socio-economic class, does not engage in smoking, alcohol consumption or any form of drug abuse, vegetarian by diet. There is no history of cancers in his family. Personal history. History of native treatment for past 1 month for the presenting complaints. Not a known case of diabetes mellitus, tuberculosis, hypertension, cardiovascular disease, HIV, asthma. No similar complaints in the past. No history of previous surgery or long-term drug therapy. No history of blood transfusion, prolonged hospitalization. No history of drug allergy in the past.
Okay. Proceed, ma'am. Proceed. Oh, so
okay.
You completed your summarize your history first. Summarize your history, ma'am. From history, what is the provisional diagnosis?
Sir, the patient is an old man, is an old gentleman, 64-year-old, who presented with. So provisional diagnosis, obstructive. It more likely seems to be an obstructive jaundice due to the presence of yellowish discoloration, clay-colored stools associated with itching.
Okay.
And associated with loss of appetite and weight, suspects it to be due to malignancy, sir.
So what makes you to tell this as a malignant etiology?
So one, the age of the patient.
Okay.
Age and the onset of presentation. 2, the duration. The duration is acute within 5 months.
Okay.
3rd, the loss of appetite and loss of weight.
Okay. So, okay. Proceed, ma'am, please.
Yes, sir.
What was the diagnosis? Obstructive jaundice because of malignancy. That is what you are coming to say, right?
Yes, sir. More likely due to malignancy.
So, how you are saying it as an obstructive jaundice? Why not hemolytic or other hepatic jaundice from history? What are the
So there is passage of white stools, and there is history of melena for 7 days.
History of
melena, sir.
melena. Okay. So
Yes, sir.
melena is not suggestive of obstructive gastritis. Melena is
Yes,
black
sir.
tarry stool.
Black
That is
tarry
because
stools,
of
upper
that is
GI
because
bleed.
of okay. What determines upper GI surgical anatomy? Above which it is called as upper gastrointestinal tract, and below which it is called as lower gastrointestinal tract. What is the structure that differentiates it?
Ligament of
What is the
Treitz.
ligament? Oh, good, good. Ligament of Treitz. Above is called as upper GI. Below it is called as lower GI. Why it is black tarry tools? What is the why the what gives the color black? Whether the lower GI bleeding will present with the black tarry stools?
No, sir. Due to the action of pancreatic enzymes and oxidation
Pancreatic
process, it
enzyme.
turns
No,
black.
no. This is due to action of stomach acid. Okay, HCl.
Okay, sir.
Okay. The black color is due to the action of acid over the heme.
Yes.
Okay, good. Go with your examination.
Yes, sir. Examination, general survey. The patient is conscious, oriented, ill-built and ill-nourished, afebrile, icterus noted over the sclera and over the skin of the palms, no generalized lymphadenopathy, clubbing and bilateral pedal edema present. Pallor could not be appreciated due to icterus, scratch marks present on numerous places of the body, long and shiny nails noted. Vitals stable, pulse 72 per minute, blood pressure 130/90 mm of mercury taken in the right arm in the sitting posture, temperature 38 degrees Celsius, respiratory rate 16 breaths per minute.
Okay. So why the icterus is noted first is sclera?
So it has high propensity for the deposition of bilirubin pigments due to the high elastin content in sclera.
Okay. Approximately at what level of serum bilirubin it can be detected in sclera?
2.5 milligrams per deciliter, sir.
Okay, okay. So what is the importance of clubbing in this patient?
So clubbing can indicate hepatic cell failure in case of cirrhosis or any other liver dysfunction, sir.
What are the other features of the liver cell failure? What are the features of
Distended or
liver cell
dilated
failure?
vein. Sir, sorry.
What are the features of liver cell failure?
Distended or dilated veins over the inspection in the abdomen.
Okay, you can go from head to foot, right? That will be easy for you so that you won't miss any points. Allopexia,
Okay.
then
Oh,
signs of liver cell failures. This is an important question. It will be given in medicine probably.
okay.
So it's allopexia, it's the first allopexia. Then what you will see in eyes in liver cell
Icteric.
failure. Okay, stress, xanthal asthma, parotitis, that is parotid swelling, dry lips, and then coming to the chest region, spider navy, gynecomastia, coming to the abdomen, what is caput medusa? Caput medusa is dilated abdominal vein. Okay,
Yes, sir.
the veins over the anterior abdominal will get dilated because of increased portal hypertension. Not only in this region, in other regions of portosystemic shunt, it will get dilated in portal hypertension. And
Yes.
clubbing will be there, pharma, erythema, uh, and scrotal edema in some cases, ascites, field edema. நிறைய இருக்குமா லிவர் செல் ஃபெயிலியர் சயின்ஸ் அதை ஒரு டைம் படிச்சுக்கோங்க அளவுக்கு புக்கில் கொடுத்துருப்பாங்க நல்லா இல்லைன்னா
Yes,
ஹெப்பன்சன்ல
sir.
இருக்கும் ஓகே ஸோ அதெல்லாம் தெரிஞ்சுக்கணும் வாட் இஸ் த சிக்னிஃபிகன்ட் ஆஃப் ஸ்கிராச் மார்க் இன் திஸ் பேஷண்ட்
So it indicates the biles are also being deposited in the skin, and because of that,
so that is
patient.
will be there okay the significant significant I mean it is also significant finding because there will be pruritus, generalized pruritus in case of liver cell failure. Okay, this is due to deposition of the bile salt that irritates the nerve ending, and this will present as a pruritus. Okay, whether there will be failure in this patient or not. Whether
So there
the
is more
patient
chance
with liver
for
cell
failure,
failure,
but
how?
but it is difficult to elicit because there is yellowish discoloration present.
It's okay, but for this purpose, I mean, if it is difficult to elicit, we cannot leave the patient untreated for anemia, right? So we should know whether there will be anemia in this case or not.
Yes, sir.
For your patient, you are saying that there is a ictus for this patient. If anemia is there for this patient, then it will go unnoticed, right?
Yes, sir.
So you should anticipate whether the anemia will be there or not. So whether from history point of view, can you tell whether your patient will be anemic or not?
So more likely anemic.
And so what are the history suggestive of anemia for this patient?
So loss of weight and loss of appetite.
Okay, can lead to nutritional anemia. Then
And the patient is was also
history of black tarry tools, right? So the
yes, sir.
patient has ongoing upper GI bleed. So to present as a melena, minimum of 50 to 100 ml of blood is required in the stomach. So there was a blood loss in the abdomen. So patient will be
Yes.
anemic.
Yes.
So for these patients, anemia can be seen on other sites. Okay, as
Yes,
icterus
sir.
can be seen in other sites. What are the sites where you can see icterus clinically? Other
So
than
bulbar
possible
conjunctiva
conjunctiva? Okay.
under the surface of tongue.
Okay.
The soles of palm and feet.
Okay. So the entire skin can, okay, expand the
Skin
entire
can
skin.
also. Yes, sir.
What will be the nature of hair in liver cell failure?
So dry.
First thing, alopecia, hair fall will be there,
Hair
followed
fall.
by, and the hair will be brittle,
Brittle.
dry brittle hair. Okay,
Yes,
hair
sir.
can be cut into pieces easily by hand even. Okay,
Yes, sir.
okay. Then what are the respiratory features? I mean, respiratory system features that can be seen in liver cell failure. So you have mentioned that respiratory rate is around 16 beats per minute.
Yes,
Okay.
sir.
So what are the findings that can be seen in respiratory system in case of liver cell failure? What are the things you are anticipating, expecting?
Tachypnea.
Okay. The most important function of liver is protein production, protein synthesis. These proteins are important for maintaining the oncotic pressure. Hope you can
Yes, sir.
understand. So
Yes, sir. Albumin.
oncotic pressure will keep the blood intravascularly. Okay, it helps in holding the blood and the water content inside the vessel. This albumin or this protein molecule cannot cross the blood vessel wall because of its larger size. So the oncotic pressure inside the blood vessels will be more, so that the extravascular blood will be pulled into the blood vessels. In case of liver cell failure, the protein will be less, total proteins. So the oncotic pressure will be low. The
Yes, sir.
oncotic pressure will be low, so that the blood and the water content cannot be held up within the intravascular area. Because of hydrostatic pressure, the blood and the water product will extravasate from the blood vessel. This can cause pulmonary edema.
Yes, sir.
Okay, this can cause pulmonary edema. Tachypnea can occur. Okay, so tachypnea can be present in case of liver cell failure. So, in history, you have mentioned some features of liver cell failure, but
Yes,
respiratory rate is 4 minutes. So that's a contradictory point in the presentation here. Okay. Okay, no
okay,
issues.
sir.
Go for next slide. Proceed further.
Inspection. Patient is in supine position with arms kept on either side and exposed from mid-chest to mid-thigh. Before the examination, consent was got from the patient. Inspection. Normal shape and contour of the abdomen. Umbilicus position normal and inverted. Skin over the abdomen. Multiple scratch marks present. No scars, pigmentation or engorged veins. Movements. All quadrants move normally with respiration. Visible gastric and intestinal peristalsis and visible pulsation. A swelling is noted just in the right hypochondrium extending over the lumbar region, approximately of size 5 × 3 cm. Pyriform in shape, below the right costal cartilage. External genitalia normal.
Okay. Proceed, ma'am. Proceed.
Yes, sir. Palpation. No localized raise in temperature over all the quadrants of the abdomen. Abdomen soft, non-tender, no guarding, no rigidity. A globular mass, approximately of size 5 × 3 cm, is seen extending from right hypochondrium to right lumbar region, which is firm in consistency, non-tender, moves with respiration. Side-to-side motility is noted, with lower and medial and as well as lateral border palpable. Lump becomes less prominent with a head-rising test. Can insinuate fingers below the costal margin. No other palpable mass noted. No hepatosplenomegaly, hernial sites normal. No renal angle tenderness. No supraclavicular lymph node enlargement noted.
Proceed, ma'am.
Percussion. Dull note over the lump present, which is continuous with liver dullness. Normal percussion noted over the other quadrants of the abdomen. Shifting dullness test negative. Auscultation. Normal bowel sounds heard. No bruit, venous hum or any arid sounds.
Okay. So come to inspection now.
Yes, sir.
Okay. So here, what is the importance of umbilicus in examination of abdomen?
So the normal position of umbilicus is midway between the xiphisternal junction and the symphysis pubis. So when it is present above its normal position, it indicates that a mass is present extending from the pelvic region. If the umbilicus is pushed down, it indicates it can be due to ascites or any mass arising above the level of umbilicus.
Ascites or any mass. Whether the ascites can be localized only in upper abdomen.
So no, sir. No,
then how
sir.
could be the ascites be a cause for umbilicus pushed downwards?
No, sir. Sorry. That is for eversion.
Okay. In case of ascites, the umbilicus will be flushed up to the surface.
Yes, sir.
Okay. In case of any mass arising from pelvis, the umbilicus will be pushed upwards. In case of upper abdominal mass, it will be pushed downwards.
Yes, sir.
Okay, this is the significance of umbilicus. Okay, and so what is VGP and what is VIP? Where you can see VGP? Visible gastric peristalsis is seen in what conditions?
So gastric outlet obstruction.
Yes. Okay. So here you should know about the physiology of peristalsis. What are the cells that stimulate peristaltic movement in the gut? Okay, that you can read from our what is that book called as Hindu Purana for physiology. So we are not going to deal much about it. And what is the importance of VIP, visible intestinal peristalsis? If VIP is present, what it signifies?
Any stricture, valvulus or obstruction.
Any small bowel obstruction. Okay, any obstruction, any intestinal obstruction can present VIP. Okay. So how will you determine? How will you find or how will you detect the VIP? What will be the question in examining the patient to find VIP is there or not?
The patient is asked to lie in supine position, and we observe the patient tangentially. We look at the patient tangentially.
From which end of the patient?
From the head end of the patient.
No, examiner should be at the foot end of the patient to see the VIP. Okay.
Yes, sir.
So we mentioned about a swelling in the right hypochondrium. Okay, what are the possible swellings that can arise from right hypochondrium? What are the possible swellings? Can tell anything that can arise from that can present as a right hypochondral swelling. Any condition that can present as right hypochondral swelling or
So hepatomegaly,
okay.
gallbladder swelling.
Okay. First, whenever such a question is asked, to avoid forgetting the points, it can go from from the superficial layer to deep layer. Okay, start from skin.
Sure.
Even skin swelling can present the right hypochondrium, right?
Yes, sir.
So any lipoma, even tendinosis can occur in the abdomen. So you can start
Yes.
from that. Can hemangioma in the hemangioma in the skin can also present, and then go deeper. There will be some liver pathologies, so specifically right lobe pathologies. What are the liver pathologies? This can be further divided into benign and malignant. Okay. From benign pathologies, mean any tumors can also present. Some hydatitis can be present. Infective causes. A liver abscess can be present. And empyema of gallbladder pathologies, gallstones. When gallstones at acute stage can present as enlarged gallbladder. At chronic condition, it can go for atrophic of gallbladder also. And even hepatic flexure mass in the intestine you have a hepatic flexure, right? So that mass
Yes.
or the swelling the intestinal hepatic flexure can also present as a right hypochondrial swelling. Then even stomach sometimes can be pushed towards the left side. The pylorus of the stomach can have some growth or any pedunculated mass from the neighboring structures. So what are the structures present in the right hypochondrium? Liver, then
Gallbladder,
okay,
right, hepatic flexure,
okay. These are the important structures present. And others maybe sometimes the stomach can even enter into the right hypochondrium, the pylorus of the stomach,
yes,
and the duodenum also. Okay. So what is the significance of external genitalia normal in this case? What are the things you're expecting in external genitalia here in case of right hypochondrial swelling or obstructive jaundice? What are the things you're expecting in external genitalia? I said
so
previously because of
in case of liver cell dysfunction, they can be bleeding due to
okay.
opening up of portal anastomosis. They can be bleeding over there if present.
புரியலமா என்ன சொன்னீங்க?
So in case of liver cell failure, they can be bleeding due to opening of portosystemic anastomosis.
ஓப்பனிங் ஆஃப் போட்டோ சிஸ்டமிக் அனஸ்டமோஸ்னால ப்ளீடிங் இருக்காது. என்ன இருக்கும் டைலேட்டட் வெயின்ஸ் இருக்கும். ப்ளீடிங்
Yes.
ஏன் வரலாம்னா விட்டமின் கே அப்சர்ப்ஷன்லாம் டிஃபெக்டிவா இருக்கும். ஏன்னா விட்டமின் கே இஸ்
Yes.
விட்டமின். அதனால விட்டமின் கே டிஃபரெண்ட் கிளாட்டிங் ஃபேக்டர்ஸ் எல்லாமே குறைஞ்சிரும். அதனால பேஷண்ட் வந்து ப்ளீடிங் மேனிஃபெஸ்டேஷன் வரலாம்.
Yes.
கரெக்ட் மேல் பேஷண்ட்னா ஒரு ப்ரெஃப்யூசல் ப்ளீடிங்லாம் வரலாம். ஓகே. இன்னொரு முக்கியமான விஷயம் வந்து எடிமா இருக்கும். ஸ்க்ராட்டல் எடிமா, பினல் எடிமா கேன் பி present in case of liver cell failure.
Okay, sir.
In chronic obstructive jaundice patients. So what is the diagnosis here? What is the diagnosis?
So obstructive jaundice.
Diagnosis சொல்லுங்க. அப்படி சொல்லக்கூடாதுல்ல, ஃபுல்லா சொல்லணும்ல. லாஸ்ட் ஸ்லைடுக்கு வாங்க. லாஸ்ட் ஸ்லைடுக்கு வாங்கம்மா. A 60-year-old man presented with right upper abdomen pain was diagnosed to have obstructive jaundice, which may be of malignant etiology, with or without liver cell failure signs. Okay, if you all know.
Yes.
Okay. So, என்ன இன்வெஸ்டிகேஷன் பண்ணலாம் உங்க பேஷண்ட்டுக்கு?
So ultrasound.
Okay.
Ultrasound of abdomen.
Hmm.
Then contrast enhanced CT.
Okay.
Then biochemical investigations can be done.
என்ன பண்ணலாம் biochemical
Like
investigation?
total blood count, hemoglobin estimation, serum creatinine, serum uric acid, total bilirubin, direct bilirubin, SGOT, SGPT, total protein estimation, alkaline phosphatase, prothrombin time.
Okay. இதுல எதெல்லாம் ஆல்டர் ஆயிருக்கும் obstructive jaundiceல?
So there will be increase in total serum bilirubin, especially that of direct bilirubin.
Okay.
There will be increase in alkaline phosphatase level.
Okay.
And prothrombin time will be increased due to the less availability of vitamin K dependent anticoagulants 2, 4, 7, 10.
Okay. So, whether proteins will be decreased in this case?
No, sir.
Why?
So there is no hepatic cell dysfunction.
ஆமா, இந்த இடத்துல நிறைய பேர் கன்ஃபியூஸ் ஆவாங்க. எப்படி கன்ஃபியூஸ் ஆவாங்கன்னா, நம்ம வந்து விட்டமின் கே டெஃபிஷியன்சி இருக்குன்னு சொல்றோம், ஆனால் லிவர் நல்லதா இருக்குன்னு நினைப்பாங்க. அப்கோர்ஸ் லிவர் இஸ் வெரி நார்மல், லிவர் கேன் ப்ரொடியூஸ் கிளாட்டிங் ஃபேக்டர்ஸ், பட் விட்டமின் கே அப்சார்ப்ஷன் குறைஞ்சிடும், அதனால வந்து கிளாட்டிங் ஃபேக்டர்ஸ் ப்ரொடியூஸ் ஆகாது. ஸோ how will you treat if there is a bleeding manifestation for this patient?
So injection of vitamin K.
What are the two forms it is available? விட்டமின் கே ரெண்டு இதுல வரும்ல, ஒன்னு வந்து அனிமல் ஃபார்ம், இன்னொன்னு பிளான்ட் ஃபார்ம். பைட்டோமினோடயோன்.
No, sir. Yes. Minadione.
ஓகே, அதை படிச்சுக்கோங்க. ஓகே.
Yes, sir.
ஸோ விட்டமின் கே 1 cc IM ஃபார் அட்லீஸ்ட் 3 days போடுவோம். ஸோ பிடினா ப்ரோத்ராமன் டைம், நார்மல் ப்ரோத்ராமன் டைம்.
So it is 15 seconds, less than 1.5, 15 seconds.
15, okay. What is normalized, international normalized ratio? What is normal INR?
So it is less than 1.5.
Less than 1.5. 1.5 is normal.
Yes.
Not more than or less than, okay.
Yes.
So what are the significance of RFT in this case? If RFT is elevated, what are the things you are suspecting in this case? First issue, metastasis to kidney.
Yes.
Okay. இன்னொன்று it can be a prevenient because of increased bilirubin, kidney damage can occur.
Yes.
As the bilirubin, if there is obstruction, it will have a reflex entry into the blood. So it will be excreted through kidney. When it is excreted to the kidney, it can damage the nephrons.
Yes.
It will get deposited in the base membrane of nephron and can cause damage. It can lead to nephropathy. So this can also cause increased RFT. And of course, liver cell failure can cause infection because of reduced protein levels. Patient is small prone for any infection. This infection can cause sepsis, which can further affect the kidney. Okay. So, what is Courvoisier's law?
So a non-tender palpable gallbladder in a patient of jaundice is not normally due to stone obstructing the bile duct, but it is due to other causes.
Okay. Then how will you proceed? What are the other investigations you will be going for? You said about ultrasound, CECT, and then if ultrasound was normal,
So see ERCP or MRCP.
ERCP-யா MRCP-யா என்ன பண்ணலாம்? ரெண்டுமே வேற வேற இல்லைங்க.
Yes, sir.
First, I will go for MRCP because it is a non-invasive investigation.
Yes.
Okay, it is a non-invasive investigation, and it is used for delineating the anatomical structures and the anatomical continuity of the biliary tract. Okay, so if you find if it find to be a gallstone, you have done an ultrasound. An ultrasound shows around 7 mm calculi in the gallbladder, multiple stones in the gallbladder, maximum of 7 mm, and also some gallstones are present in the CBD. So what is this condition called as? If gallstones are present in gallbladder, it is called as cholelithiasis.
Yes.
If the gallstones are present, if it is present in gallbladder, if it is present in the CBD, it is called as cholelithiasis. For this condition, how we will proceed? Because stone in the gallbladder.
Placement.
No, first is that you should not go for surgery at the earliest chance. Okay, you can try some ERCP here. Okay, you can go for the ERCP.
ERCP with T-tube.
No, T-tube can be done by surgical procedure. Okay,
yes,
if the stones, if patient is fit for surgery, we can go for open cholecystectomy with CBD exploration and T-tube placement.
Yes, sir.
Okay. If patient is fit for surgery.
Fit for surgery.
You can go for open cholecystectomy followed by a CBD exploration, and you will remove the stones in the CBD and you will insert a T-tube. So the T-tube will have three limbs, right? One limb will be inside the hepatic duct, one limb will be inside the ampulla of Vater, and one limb will be one limb will be brought outside the abdomen cavity through an incision in the anterior abdominal wall. Okay,
yes,
so that the bile secretor will come out through the one limb that is kept outside the abdomen cavity. Okay, so that the patient will not have any stasis and there will be no obstructive jaundice features here.
Yes.
Okay, this is more probably used in case of periampullary carcinomas. In periampullary carcinomas, there will be obstruction at the level of ampulla of Vater. So placing a T-tube can give a palliative effect by reducing the jaundice level. After reducing the jaundice level, you can go for definite treatment. So if patient is not interested, not fit for surgery, then you can go for ERCP. In case of gallstone disease, ERCP is done and sphincterotomy will be done. The sphincter will be incised and sphincter will be cut so that the tone of the sphincter will be lost and it will become lax so that the stones can pass out easily. And then you can have a stent placement. Metallic stent can be placed there so that the sphincter will be kept open by the stent placed there so that the stones can pass out easily. These are the two things that can be done with the ERCP. Okay, here in your case, it is a malignancy, right? So in case of malignancy, what are the investigations you will do pertaining to malignancy? If the case of obstructive jaundice comes to you, what are the investigations you will be doing other than the routine investigation? So you have done your MRCP even, which is suggestive of periampullary carcinoma.
Tumor markers.
What are the tumor markers you are expecting here?
CA 19.9.
No, more than that, we should go for a metastatic evaluation. Whether the tumor spread anywhere else. Of course, PET is the single scan that can detect any mets in the entire body. If PET is not available, you can go for CT test, CT brain, and of course creatal survey or bone scan can also be done. Okay.
Yes.
So if it is operable means it has not any, it has got no attachments. The complete resection of tumor with the prescribed clearance can be given. What are the surgeries you will proceed with in case of periampullary carcinoma?
So Whipple's procedure, pancreatic or duodenectomy.
So what is Whipple's procedure comprise?
So it is en bloc removal of the head of the pancreas with the adjacent duodenum and cholecystectomy.
The distal gastrectomy பண்ணிடுவோம், followed by cholecystectomy and the en bloc removal of the tumor along with the head of the pancreas and duodenum. Okay, you have done this. So இப்போ ஸ்டார்ட் பாதி இருக்கு, ஹெப்பாட்டிக் டக்ட் தனியா தொங்கிட்டு இருக்கு, ரீகன்ஸ்ட்ரக்ஷன் எப்படி பண்ணலாம், என்ன பண்ணுவீங்க?
So for reconstruction, jejunum is brought and it is arranged in row formation, and it can either be attached side to side or end to end with the remaining distal part of the pancreas, and the remaining common hepatic duct is attached to it later.
அது நீங்க சிம்பிளா சொல்லணும்னா cholecystectomy, pancreaticojejunostomy and anterior gastrojejunostomy.
Yes.
Okay, இந்த மூணு பண்ணுவோம். மூணு பண்ணிட்டு ஒரு jejunostomy பண்ணுவோம்.
Yes.
Okay. To reduce the pressure, what are the complications you are expecting in case of Whipple's?
So dumpling, delayed gastric emptying.
Okay.
There might be pancreatic or bile leak.
Okay.
Sepsis, any focus of infection, abscess formation, a risk of hemorrhage.
Okay, nice. So what type of anesthesia will you be using for Whipple's surgery?
So general anesthesia.
Okay. General anesthesia, sometimes you can go for a general anesthesia with epidural anesthesia for post-op pain relief.
Yes, sir.
Epidural anesthesia along with general anesthesia. So that the epidural catheter can be kept even after the surgery, and it can be used for post-op pain relief. So what is the incision used for Whipple's surgery?
So transverse incision or rooftop incision.
Name that is given for that rooftop incision.
Chevron incision or bilateral subcostal incision.
Chevron incision. Okay. So if the tumor is not resectable,
yes, sir,
will do. The patient is fit for surgery.
If the patient is unfit for Whipple's procedure, then if at all there is tumor metastasis or entrapment of the vessels, then a triple bypass can be done.
What are the triple bypass comprises of?
Choledochojejunostomy, cholecystojejunostomy, gastrojejunostomy, and pancreaticojejunostomy with bowel-to-bowel enteroanastomosis.
ட்ரிபிள் பைபாஸ் தானே சொன்னீங்க, 4-5 சொல்றீங்களே, 3 இடத்துல பைபாஸ் பண்ணணும்.
Yes, sir.
Gastrojejunostomy, okay, then pancreaticojejunostomy, then cholecystojejunostomy, okay, not choledochojejunostomy.
Yes, sir.
Okay, ஏன்னா periampullary region தான் நமக்கு டியூமர் இருக்கு. Okay. So what are the periampullary carcinomas? From where the periampullary carcinoma can arise?
So from the distal end of common bile duct. Then any carcinoma involving the ampulla of water, duodenal carcinoma or pancreatic head carcinoma. Any carcinomas arising within 2 cm within the region of ampulla of water comprises periampullary neoplasms.
Okay. So you will do triple bypass in conditions where the complete resection is not possible. So that tumor will be present inside the body, but for palliation purpose, you can go for triple bypass. Because in case of obstructive jaundice, in case of periampullary carcinoma, there may be intestinal obstruction also. Not only obstructive jaundice will be there. In case of periampullary carcinoma, entire duodenum can be occluded. So patient cannot eat, patient will have vomiting, continuous vomiting. So to prevent this, we can go for triple bypass, anterior gastrojejunostomy, so that the food will be entering into the jejunum directly. As there is a mass in the periampular region, the bile cannot enter into it, so that we will go for cholecystojejunostomy, so that the bile can reflexly go into the gallbladder, and from gallbladder it can directly enter into the jejunum. Of course, jejunostomy can be done. This comprises of triple bypass. A tumor will be there at present. Okay, so
yes,
these are the things you will be going for. So, what are the other techniques you can do for this palliative procedure other than triple bypass? If there is no obstruction, intestinal obstruction, patient only has obstructive jaundice, you can go for even single bypass. Cholecystojejunostomy can alone be done.
Yes, sir.
Okay. So, what are the electrolyte imbalances you are expecting in case of obstructive jaundice?
So if vomiting was present,
water will be lost.
Yes, sodium, water will be lost, sodium, potassium chloride loss will be present.
Maximum potassium loss அதிகமா இருக்கும். Okay. Diarrhea sodium loss இருக்குங்க. இதுல vomitingல potassium loss அதிகமா இருக்கும். Even in the resectable tumor, not resectable tumor சொல்லிட்டு இருந்தோம்ல. What are the criteria to tell the tumor is resectable or not?
The tumor should not involve any of the vessels nearby, portal vein or superior mesenteric artery, and it should not have metastasis either in the peritoneum or in the liver, elsewhere within the abdomen.
Then one more point is that there will be a fat plane between all structures. Okay, to have a cushioning effect. So that fat plane between the tumor and the superior mesenteric artery and other celiac trunk branches should be preserved.
Yes, sir.
Okay, fat plane will be there between all the structures to provide a cushioning effect and supportive protective effect. And this fat plane between the tumor and the superior mesenteric artery and celiac branches should be preserved here. So,
yes,
what are the signs of inoperability in case of periampullary carcinoma?
Vessel entrapment.
Okay. What vessel you are expecting to be entrapped here? As I said already. What are the vessels?
Superior mesenteric vein, superior mesenteric artery.
Okay. What is the main blood supply for liver?
From celiac trunk, common hepatic artery. The main blood supply is from the main nutrient is from portal vein.
Okay. So invasion of superior mesenteric vessels, both artery and vein, portal vein, and celiac axis, and even IVC. Okay. These are the signs of inoperability, along with if there is lymph node metastasis. Okay. And in case of peritoneal metastasis, and if patient presents with the ascites, these are all inoperable signs. If patient presents with ascites, periampullary carcinoma with ascites, periampullary carcinoma with peritoneal metastasis, periampullary carcinoma with distal metastasis, with nodal metastasis, periampullary carcinoma invading the IVC, superior mesenteric vessels, portal veins, and celiac axis are inoperable. Okay. So, what are borderline resectable cases? And the inoperable ko operable நடுவுல ஒரு group இருக்கு. Borderline inoperable. Okay, let me tell you. One on the unilateral or bilateral SMV portal impingement. And the superior mesenteric vein portal vein full invasion இல்லாம that just causes impingement. ஒரு அபட்டிங் மாதிரி அபட் மட்டும் பண்ற மாதிரி ஜஸ்ட் அழுத்தும் தமிழ்ல சொல்ல போனா ஜஸ்ட் கம்ப்ரஸ் ஓவர் இட். ஓகே, இட் வில் நாட் இன்வேட் தி எஸ்எம்வி ஆர் போர்ட்டல் வெயின், பட் இட் வில் அபட் இட் ஆர் இட் ஜஸ்ட் கம்ப்ரஸ் ஓவர் இட். அது ஒண்ணு. இன்னொன்று வந்து இஃப் சுப்பீரியர் மெசென்ட்ரிக் ஆர்டரி இஸ் அபட்டட் அரௌண்ட் less than 180 degree, ஒரு சைடு மட்டும் இஃப் இட் இஸ் பீயிங் கம்ப்ரஸ்ட். Okay, if either one side of the vessel it is getting compressed, it is not enclosing the vessel, it is compressing the vessel from one side.
Yes.
Okay, these are all the conditions of borderline resectable tumors. Nothing just involving the borderline resectable na the vessels வச்சு சொல்றோம். superior mesenteric vessels and portal veins full enclose பண்ணி invade பண்ணாம just compressing over the vessel.
Yes.
Okay. So, what is the mortality of Whipple's procedure?
So 20 to 40%.
Okay. So, do you know in what way you can go for a Whipple's procedure? Whether, as you said, only chevron fissure incision and open Whipple's procedure is done commonly, or any other ways is there for doing, like laparoscopy?
So laparoscopy by 4 ports.
Yeah, laparoscopic Whipple's procedure is also being done, but it requires high expertization. But it is also being done, but not routinely done. Okay,
Yes,
laparoscopic Whipple's is also done. So, any other doubts for you, ma? You shall come to this session. Or do you know? So can you tell about some chemotherapy agents that are given for periampulary carcinoma if it is not resectable, not operable?
So 5-fluorouracil and gemcitabine.
Gemcitabine, okay. We have few regimens for it.
Yes.
CMF regimen is there. It is the old and commonly used regimen. Okay, CMF regimen and the MF regimen. And recently we will be going for gemcitabine.
Yes, sir.
But in cases of periampulary carcinoma, the role of chemotherapy and radiotherapy is very limited for long-term survival.
Yes, sir.
So it is usually not advised. But in case of inoperability, we can go for it. But its role is not that much encouraging us to go for it. Okay. So CMF regimen includes cyclophosphamide, methotrexate, and 5-fluorouracil. And MF means mitomycin and 5-fluorouracil. Okay.
Yes, sir.
These are the things can be done. And for pain relief, what can be done for this patient? If it is not operable, for pain relief, what can be done?
So opioids should not be given.
சரி, வேற என்ன பண்ணலாம்? அது ஒன்றும் இல்லை, இன்னைக்கு ஃபேஸ்புக் பார்க்குறப்ப எங்கள் காலேஜில் மதுரையில் ஒரு அனஸ்தீஷியா ப்ரொஃபஸர் போட்டிருந்தாரு. அவர் வந்து ஒரு ப்ரொசீஜர் பண்ணியிருக்காரு பெரியாம்பலி காசனமா பெயின் ரிலீஃப் அனஸ்தீஷியாவில். அதனால இந்த கேள்வி கேட்குறேன். ப்ராப்ளம் தெரிஞ்சிருக்க வாய்ப்பு இல்லை, நானே சொல்லிடுறேன். சீலியாக் பிளாக் பண்ணியிருக்காங்க. சீலியாக் பிளெக்சஸ் இருக்குல்ல, சீலியாக் பிளெக்சஸ் பிளாக். Okay.
Yes, sir.
Ultrasound guided, image guided celiac plexus block பண்றாங்க anesthetic.
Yes.
Okay, this can also used for reducing the pain in case of periampulary carcinoma. So CA என்ன டியூமர் மார்க்கர்ஸ் பாப்பீங்க? CA 19.9 சொன்னீங்க.
Yes, sir.
வேற டியூமர் மார்க்கர்ஸ் எல்லாம் பார்க்கலாம்.
So for CEA.
CEA. What is CEA? CEA abbreviation என்னமா? Carcino embryogenic antigen. Okay, simple தான். ஒன்றும் இல்லை. Carcino embryogenic antigen. Okay, so நம்ம left supraclavicular lymph node பத்தி சொன்னோம்ல. What is the sign called?
Yes, a Troisier sign.
Okay, what is Troisier sign?
It is seen in hypocalcemia.
சரி, ஓகேங்க. அதே மாதிரி அதே நேம்ல அப்டமன்லயே ஒரு சைன் இருக்கு. In case of any abdominal malignancy, யூசுவலா pancreatic malignancyல இருக்கும். இந்த மைக்ரேட்டரி
Maybe
கண்டிஷன் இருக்கு. இல்ல ட்ரௌசி சைன் ரெண்டு இடத்துல வரும். ஒன்னு நீங்க சொன்னது கரெக்ட், டெட்டானியில ஹைப்போகால்சிமியால கார்போபீடல் பேட்டர்ன் சொல்ற கால்ட் ட்ரௌசி சைன். அண்ட் ஆல்சோ migratory thrombophlebitis in case of pancreatic malignancy. Migratory thrombophlebitis also called as Strauss sign.
Yes.
Okay. So okay, now let's complete the session with this now. So any doubts na நீங்க என்ன கால் பண்ணி கேளுங்க, ஒரு ப்ராப்ளம் இல்ல. So guys ஏதாவது டவுட்னா யாருனோ எனக்கு கேட்கலாம். ஓகே. அண்ட் நைஸ் பிரசன்டேஷன் நல்லா ஒர்க் அவுட் பண்ணிருக்கீங்க. நல்ல பிரசன்டேஷன். ஹிஸ்டரி நல்லா இருந்துச்சு. இன்ஃபேக்ட் இது வரைக்கும் பண்ணதுல ஹிஸ்டரி உங்களுக்கு நல்லா இருந்துச்சு.